So I'm glad to see everybody here. It's nice to see all the diehards. But this is a great talk. Dr. Blumenthal has, sort of made this a specialty of his, and somehow he's getting all these revision cervical arthroplasties. I like putting the primaries in and let him do the revisions. But in any case, he's put a lot of work into this, so give him your attention and take it away, Scott.
No sarcasm in that introduction. I didn't. All right, well, good morning to everybody, and these are my disclosures since this is a CME activity. So we're going to start off with kind of the introduction, and I'm not going to spend a ton of time laying the foundation for cervical arthroplasty because this is a very friendly group when it comes to acceptance of the technology. But the predecessor, obviously, ACDF has been around for a long time, and the most recent statistics, even though the prevalence of disc replacement in the cervical spine is increasing in the States, it's still well over 80% of cervical pathology that's treated anteriorly is treated with the ACDF. Obviously, when thinking about arthroplasty, you still want to do and abide by the principles that have worked to get patients better, and that is restoration of the height of a collapsed disc, decompression of the neuroforamen and the cord, and maintaining or restoring sagittal alignment. Obviously, the problem and the complication of ACDF, pseudarthrosis, is alleviated with disc replacement, but you'll be able to see we have our own barrel of complications that we'll have to deal with. Obviously, what we're trying to avoid, the holy grail, is adjacent segment degeneration. This paper has been quoted way too often, but that usually means it's a pretty good paper. Why? But the real question, and there's some answers, some not. Why is there increased incidence? There's the biomechanical reasons. There's impingement with a plate, a longer plate on the next level, so we've gone to shorter plates when we do ACDF. Obviously, excess motion and fatigue, and then kind of that ever the thing that's always in the background is the possibility of genetic factors, and I think we underestimate that. I think some people are just prone to adjacent segment, just like they are to heterotopic ossification. So, heading into cervical disc replacement, it's really gained as a widespread acceptance as you would think. Surgeons are slow to jump on board, both from an academic reason as well as financial reasons. It certainly has been more accepted than lumbar arthroplasty, but there's some reasons. Obviously, you follow the money, and this is not the most academic slide I put in, but it shows the growth. And obviously, industry is going to pay attention if the market demands it. And if you look at a 12 to 13% yearly growth, that's going to be something that everyone's going to jump on. And that's why there are 8 cervical TDRs, and I was going to say 2. We'll just say 1.5 lumbars now. But nobody gets that joke except like 3 people. But the market's huge, and I'll just kind of leave it at that. The academic interest has been unbelievable. If you look at since 2002, 2003, when the trial started in the U.S., there's been over 1,300 articles published on cervical TDR. That's a very, very well-studied technology. Now, why, amongst other reasons, why cervical arthroplasty been accepted, is because it's predictable and it's repeatable. And I love this slide. Donna did this slide, and it's just brilliant because you look at all the disc trials, and frankly, including the fusion controls, and you can really predict that, or predict how a patient's going to do. And that's kind of one of the predicates for why cervical disc replacement's been so successful. Those were all just multi-center trials, conducted different surgeons, different centers, and it really is, and it supports the uniformity of outcomes for the correct indications. Also, there's been a huge interest in meta-analysis and systematic reviews looking at various outcome measures, as you can see here. And this is just in 1 year, 16 published meta-analyses. all the studies did find outcomes at worst similar, but in many cases superior to ACDF with arthroplasty. Now getting into the meat of it, you can see people are coming in, so I did the boring stuff first. With any procedure, there are going to be failures. And the more we learn about complications, the lower the rate can be. We can handle them in a more uniform way and be able to speak kind of a common language. Modes of failure, as we'll see, and we're going to go over these in greater detail. Migration, subsidence, adjacent segment. The adjacent segment is not eliminated with arthroplasty. You'll see from the studies that it's reduced significantly. Heterotopic ossification, which was a huge issue initially, and I think has calmed down a bit as we've learned more about what's clinical heterotopic ossification and perhaps refined our technique and maybe even decreased the incidence. Recurrent or persistent posterior pathology. We've all become better anterior foraminotomy surgeons with arthroplasty than we ever were with fusion. Some more recently recognized modes of failure are osteolysis. We'll spend a lot of time talking about that. Hypermobility, which has patient factors as well as the biomechanics of certain devices. And then sizing issues, the overstuffing of the disc, which has its own issues. Undersizing has issues as well. But in clinical practice, it's very difficult to determine the incidence of rates of failure. Number one, due to the definition of what constitutes a failure. And in new technology, many of the complications are published as case reports with no denominator, and the denominator is key. So we're going to kind of focus on, since the title of the talk is revision, we're going to talk about removal or revision so that we have something to compare with our hip, knee, shoulder colleagues that have been doing these a lot longer than we have, that can quote patients, okay, what's my chance of needing revision in 10 or 20 years? We don't heretofore have that. Hopefully we'll have some numbers, at least some proposed numbers by the end of this talk. This is just the FDA guidance document on what the definition of removal or revision is. I think it's pretty intuitive. So how are we going to find these failure rates? So they're determined from large clinical series or registries with multi-year follow-up. Even though the data is difficult to obtain, if registries are voluntary, there's always the possibility of bias. Insurance databases can be used, although their focus is different from academic databases. So I used to call this the TBI registry until Donna corrected me, and I'm not going to ever argue again with a PhD statistician. This is our case series at TBI, starting from case number 1, which would have been an IDE trial case in 2003, and we just updated this month, August 24, and these are just the cervical cases. These are the number of cases by surgeon, and you can see that different surgeons have embraced the technology more than others in the practice. This was a really early paper that we published based upon some of the FDA trials that we were in to look at reoperations compared to ACDF, and you can see that there was statistically less in disc replacement these are multiple discs versus ACDF controls. Adjacent segment disease, it was trending but really wasn't powered to have a statistical statement on that. This is a paper that was just published. This is hot off the press, and this was similar to our lumbar revision paper, which Dr. Geyer was the principal author on that one, I believe. And this was enough patients with 2 to 3 year follow-up. So there's 1,600 patients, beginning with patient number 1. And we did all comers, IDE trial, non-IDE trial, on-label, off-label, hybrids, multi-levels. Whenever a cervical disc was put in, we wanted to follow these cervical discs in these patients so that we can answer the question, since our large case series here has a denominator as to what is the incidence of revision, removal, re-op, that kind of thing. And this is what we've got. We've got 24 cases, so we can say, and actually there was an article, Becker's picked this up this week and quoted this number. the 24 cases. So the incidence is just under 1.5% in our series. And if you do it by devices, it's a little bit less. Some of the other studies, now I'm going to go over some of the other studies worldwide, their numbers are a little bit higher, more in the 2 to 3% range. And I realized that their studies included patients who had index level posterior decompressions, foraminotomies for incomplete foraminal decompression. So we looked up ours, and there was an additional 4 patients. So, so we're, perhaps in that, around that 2% range if you include the posterior foraminotomies. And I have to thank Peter Derman for that, because he's doing a bigger study looking at open and endoscopic posterior foraminotomies. The 4 patients were included from our series, and the other ones were referred in, and he had a poster at the recent ESMIS meeting. So Peter's not here, but thank you, Peter. So we've got that data. We've got, at least we can answer that question, and benchmark it against hips and knees and what's in the literature. But we wanted to dig a little bit deeper, and we wanted to find out, I hate to use this term, root cause analysis of why we see failures and how we can categorize them, and then perhaps propose a treatment algorithm and an evaluation algorithm. So what we did is we took those patients and added patients that were referred in with failed arthroplasties. And we published this as well, and this got into the European Spine Journal. And this was a series. The European Spine Journal was 53 cases. Don and I have updated this up to 58 cases, and then at the end of the talk, I'll show you case 59, which we just did this week. And so we took these to really analyze why they failed, how we treated them, and perhaps how we should have treated them. But these are them, and we'll kind of go over them into more detail. The procedures can be done safely, unlike lumbar anterior revisions, which no one gets much sleep the night before you're going to do one of those. These are, I think all of us have done multiple anterior cervical revisions, and for the most part, they go pretty smoothly. So when we started this, we didn't know what we were going to find. And I was surprised, and we all were, when this popped to number 1 as the reason for revision. Osteolysis, cervical spine, whereas osteolysis and lumbar arthroplasty is incredibly rare. But this popped out as the number 1 cause. Some other things that we're seeing more and more, metal allergy we're seeing more and more, so we're asking more questions in our histories before we start doing these. And if there's any question, we do serologic testing, not just taping the device to a patient's skin, which we thought was a good thing until we found out it wasn't a good thing. So these are the 58. So the question is, are we any better? Is our profile of complications any different? So I went back to those 24 patients and looked at the profile, and it's pretty much the same. Osteolysis popped to the top as the number 1 reason for revision. So what we're seeing referred in is pretty much, I think, a standard for what we're going to see, and I think we can go back and analyze that and see what we're going to do. How about by disc? Now, some of these discs, we just didn't do that many here, but the discs that had more than 1 revision and then maybe more than 10 cases, you can see M6 had a revision rate of here 8.3%, Simplify next, Mobi-C next, Pro Disc 1%, which is, I think, pretty acceptable. Dan Rue, or I'm assuming it's Dan Rue's research person or fellow, did a review article looking at 20 studies and found an index level re-op rate of 3.9%. Again, kind of in the ballgame. It shows that we're maybe a little bit lower, but that just kind of seems to be, where things are trending out. The reasons, and we'll talk about these, interestingly enough, ongoing neck pain. Are we revising people whose discs look good for neck pain if you can't find a reason? I mean, I guess early when we didn't know what to do, we said, well, okay, let's just convert you to a fusion. And what happens, you convert them to a fusion and they come back and say, yeah, I got neck pain still. I mean, neck pain is not something, axial pain is not something that we always can promise as good a result as we can with radicular arm pain. But we'll go into that a little bit more. So this is a study from Korea, same kind of thing, 2.7%. So, again, kind of, we're seeing some other large series that show that, we're no better, no worse, maybe a little bit better. This was from the MAUD database, and MAUD has its own issues, and it's a medical device website that anybody can report to. A patient can report his own complication, surgeon, your research coordinator, whoever can report, and the top 5 complications from the MAUD database. Migration, and that's, technical or patient selection. You'd expect that early in the learning curve of new technology. Again, neck pain, that's not really a diagnosis, but it's recorded there. I thought heterotopic ossification was interesting because when we look back on our series, we didn't revise anybody for heterotopic ossification, nor should they, because most of the studies show, although heterotopic ossification occurs, maybe 10 to 15% significant HO, it doesn't really affect the clinical results. So why are you treating heterotopic ossification if the patient's clinically doing fine? And the reality is what are you going to revise it to? A fusion, and if it's already grade 3 or 4 and not moving, it's already fused. So be that as it may, I thought that was kind of interesting. To point out MAUD, they're helpful in identifying types of complications that occur, but they don't dig too deep. There's no denominator. It's voluntary reporting. And as I said, some of the reasons for revision are not reasons that in the real world you'd revise a patient. Okay, so let's benchmark it. Here's our number, say 1.5%, say just under 2 if we had posterior revisions. Here's a big study published in Lancet looking at modern hip and knee implants, and you can see that cervical arthroplasty, and for that matter lumbar, compares very favorably to the revision rate in the literature. All right, let's get back into some of the modes of failure, and here's where it gets a little more interesting because I've got case examples for a lot of these. So size. Obviously, different implants have different size profiles. You want to get as good a coverage of end plate as possible. You want to restore disc height, but you don't want to over-distract. So you've got a lot of variables that you might not have with fusion. Clinically, size mismatch can affect the patient outcome. Undersized implants may subside. Oversized implants may cause terrific facet pain, and they don't move as much. Here's an example, and this was most of these cases, I think all these cases were revised here. Some of them, index patients, were done here. This was an index patient that was done at TBI, and it was a PCM, and that's a disc that's no longer available. And you can see here, this was the smallest PCM, but it was a small patient. And preoperative planning, which we're a lot better at now, we can tailor the implant to the patient's size. But you can see it's too big, it's out in front, and patient wasn't doing well. And so this was one of the first revisions I ever did, and I'll show you the first one, but this might have been 2 or 3 that we did disc to disc. And when patients first started coming for revision, we immediately went to, okay, well, we'll do a fusion. And a lot of patients said, why? And it made us think, like, okay, well, why? Why can't we do a disc to disc? And we'll talk about the circumstances in which we can do a true revision arthroplasty like the hip and knee ducts. Height must be a good fit, besides footprint. Again, like you said, there are some discs that don't have a height profile that you might want for a smaller patient. So here's a smaller patient, a female dentist from Austin. This one we did not do the original surgery, but she presented with worsening symptoms and difficulty doing her job because of mechanical symptoms. And you can see here, the facets look okay. And what I've found is if you overstuff in surgery, you look at the facets, they look diastase, but the facets always settle. But you can see the disc height here in back and front with this particular disc, which is I think it's the Prestige LP. It's just too big for this lady. And so again, this was revised, and this is the original Pro disc. There's actually a shorter keel SK Pro disc that's good for revisions as well. And you can see it just fits her profile a little bit better. Some discs have multiple etiologies for failure. This is another female patient with 2-level Mobi with worsening neck pain. And you can see here multiple reasons. That's a Mobi height that I don't know what it is, but I think it's an 8 or something. Never used that big a height. And you can see how much it moves, and you can make the case that this is hypermobile. I'll make a more academic case for it in a few slides. But this seemed to be ripe for revision. 7, okay. And I've never used a 7. I've used 5 and 6 Mobis. So the options, again, fuse them, replace with smaller discs, do something posterior because the pain, sometimes posterior fusions help. But this one, again, we did a disc-to-disc revision with smaller implants. Here's one with sizing and positioning. And I don't mean to pick on certain discs, but most of the revisions we've done have been Mobis and M6s. With some new ones coming up quickly on the horizon. But this is another female patient with symptomatic, again, oversized prosthesis. You can see here, again, sticking out the front. You got to measure these patients and find a prosthesis that is right for them. And this one we revised, and this is a Simplify disc. A little bit longer follow-up. So as we said, positioning is more important than an ACDF cage. There's no plate in front to prevent migration, so you need to make sure it's well seated, and things can happen. This was one of ours early in the learning curve, and this was a poorly positioned Pro disc. There's a patient who had a unilateral radiculopathy, C5-6 prosthesis. The radiculopathy went away, but then appeared on the other side, and you can see that disc is too far off the midline. Did a CT scan, which shows the corner of it is impinging in the foramen, and then this patient was taken back 3 days after the index surgery and repositioned to a better position with resolution of the radicular pain. This was our one repositioning in our series. Here's another one that was referred in. This is a very sophisticated patient who said, "I don't think my disc is right." And you can see here, it's a bit posterior. It's not something any of us would leave the OR happy with this position. 5-6 was actually reasonably okay. We see a lot of coronal plane asymmetry, and I don't know that I can make that better with a revision. So obviously you work the patient out, and I just revised the pathologic one that was in the canal. It's the only study out there that I've seen that correlates disc positioning with some outcome measures. It's not the greatest study in the world, but it's the only one out there, and I think it is something that should teach us. Try to get the best positioning possible. Lateral is usually quite reproducible. AP, there's always some coronal plane asymmetries, and I tell current and past fellows is if it's a millimeter off, don't go crazy. On the AP, it's patient anatomy that really doesn't affect the outcome. Every disc has its sweet spot per se. So let's talk about some of the specific ones that we're seeing a lot of revisions for. Hypermobility. We kind of knew what it looked like on some of those first couple cases, but finally a little bit of science, and I think I think Rick participated in the study with Pat Warden out of Loyola. Pat Warden's a biomechanical engineer, probably has done more biomechanic work on cervical disc replacements than anybody out there. And he proposed a category and a classification of physiologic mobility versus hypo versus hyper. And now when I evaluate arthroplasties for hypermobility, I kind of use this scale. And if they don't really fit in and they just have nonspecific neck pain, I'm not real anxious to revise them because, like I said, neck pain is not really a good diagnosis. But hypermobility is. I know that Alex and Peter have a study looking at range of motion and outcomes as well, and it pretty much is similar to the Pat Warden study, only theirs is a clinical study, this is a biomechanical study. You put those two together, and I think you've got a way to evaluate continued symptomatic patients after cervical discs. So here's an example. This is a patient who presented with a hypermobile 5'6". Originally, her original surgeon had wanted to do 6'7", and for some reason they didn't because she had a disc there as well. But here, you measure them on your packs, you measure them in your clinic, and say, okay, I feel better as an indication of revising you, not just saying, okay, well, that's just how some discs move. And this was revised, and the other disc was done as well. This was the first revision I ever did. This is a lady who came in from Pacific Northwest who was in the original Bryan disc study, which was the first disc trialed in the U.S. She'd done great for like 6-7 years. She had some increased symptoms. Not much going on. Her canal was pretty clean. I thought that since the Bryan disc, and I'd looked at her, I'd never put one in. I thought that we weren't supposed to move this much. I was worried that the jacket on this thing was torn. And I said, okay, you're symptomatic. It looks like the disc is moving more than it was designed to do. We could revise this to a fusion. And she was the patient who said, I don't want a fusion. Why can't you do a disc to disc? And of course, I'd never done it before. So I had all the fusion stuff there. And I said, okay, if I can do it, it's safe, I'll do it. And it turns out that if the mode of failure doesn't injure the end plate too much, those circumstances you can do disc to disc. And we ended up doing it, and she did fine. We talked about metal allergy. That seems to be more prevalent in our society. So we screen with questionnaire, and then if there's any question, do serologic testing. This was another, again, it seems like I'm picking on Moby. I don't really mean to. But had some, vague symptoms. Not the worst looking disc. If that alone wouldn't alarm me too much, but was diagnosed with a nickel allergy after this was put in. And this is a disc that contains nickel. And, again, you could say maybe a little hypermobile. I didn't do the measurements there because we already had a reason that we were going to revise it, which was this nickel allergy. And so you work the patient up, still make sure there's no other pathology. Again, you can use commercially pure titanium fusion implants, do that. Or there are a couple discs that don't contain any nickel. Simplified doesn't, the M6 doesn't. And I was told that the Prestige LP doesn't contain nickel, but I didn't verify that independently, so I'm not sure. But anyway, this was converted this way. All right, so now osteolysis. This was the number one reason. The NIH definition of osteolysis, because when we first started seeing these patients, we were told we didn't understand osteolysis from the total joint docs and from the company docs that were trying to defend the prosthesis that this appears to be quite prevalent in. So, the process of destruction, progressive destruction, periprosthetic bone tissue on serial radiographs, such as progressive radiolucent lines or cavitation, the classic periprosthetic cysts that we see at the bone implant interface. And this has been one of the more common etiologies for revision. The other thing, in talking with our total joint colleagues who do shoulder arthroplasty, they seem to have found a higher radar for C acnes, used to be P acnes, now C acnes. So we did it in the first few revisions, but now in every revision, we're culturing for C. acnes, whether there's clinical sign of infection or not. I don't have the incidence. Don and I were talking about that this week. We're going to try to figure out in our revisions, once we started checking for C. acnes, what the revision rate, what the incidence is. Anecdotally, it's probably more than 50%, interestingly enough, at least with osteolysis. With non-osteolysis, probably around 20%. But, here we go. The definition, bony resorption, Wolff's Law, that's just, orthopedics 101. But osteolysis is pathologic. It's not just Wolff's Law. This is the best paper I found out there looking at trying to distinguish between bone loss and osteolysis. And this was a systematic review, 23 articles, looking at non-inflammatory versus basically inflammatory. And they had some conclusions that we can hang our hat on. Periprosthetic bone loss is common. It occurs early, and it's not really pathologic. Osteolysis is rare. It occurs later. And while there's no agreed upon etiology, I think the leading in the clubhouse is a macrophage reaction to wear from either long-term wear or early mechanical loss of integrity disc, which accelerates the disc wear. So that's my 2 cents. That's not proven yet. But some are asymptomatic, and this is a challenge. And I always show this case, and Jessica knows this case because we lived it. And this was a patient who was in the M6 trial, perfect indications, perfect placement. There's your disc, 0 neck pain, 0 arm pain, doing great. As per the protocol in the trial, and we do this in our regular patients, all our patients anyway, we have them come back for yearly follow-up. The patient kept coming back for yearly follow-up, and we would look at this periprosthetic bone loss and say, well, maybe it's just stress shielding because, here's the contact area, and it is what it is. At one of the follow-ups, the patient was having a little bit of symptoms, so we didn't know any better. So we did an MRI, and everything looked fine, and we told the patient, come back in a year, it doesn't look like anything's bad. So again, patient comes back year 4, year 5, and there just seems to be less of a platform for that disc. The vertebral body end plate is remodeling in a way that we just didn't know, we weren't comfortable with. And so we said, okay, well, let's do a CT scan. And now we know. CT scan, if you have a suspicious x-ray, CT scan is the diagnosis for osteolysis. Because look at this, the x-ray looked suspicious, but look at the cystic formation, both on the sagittal and axials around this prosthesis. And this was basically the definition: progressive periprosthetic cystic resorption around an end plate. So based upon that, even though the patient was asymptomatic, we convinced the patient to undergo a revision. Of the dozen or so M6s that we've revised, they all failed at the polyethylene weave where it interfaces with the end plate. And if you look at it, it's woven in, and as the discs move, it almost acts like a little jiggly saw. So eventually, it's gonna fail. I've seen them early where it's just frayed, and then we've seen them, and Alex and I did one where it had failed so much. Actually, I may have it in this, that the core had popped out and was sitting in front of the spine. But at any rate, this is the mode of failure, and you can see here a reason why there would be accelerated wear particles. This patient, in most of the osteolysis cases, because of the end plate loss of integrity, need to be revised to a fusion. Patient did grow C. acnes, even though there was no pus or anything clinical that would make you think. We've started getting some pathology. We see some metal wear, we see some poly wear, see macrophages, pretty typical. I think this was the case, the Alex case, and that we did together. This is a patient that was done in Germany with 3-level, minimal to no symptoms for many, many years, and then symptoms occurred. Saw chiropractor, smartly enough, refused to do manipulation, referred her to Dr. Satin, and this is what we saw. And this was the one where, hey, where's the core? And I'll show you where the core is. The core is sitting in front of the spine when we exposed the spine. There it was. And he revised this, or we did it together to this construct. Actually, I didn't stick around for the posterior. I didn't have the patience for that. We did the anterior together. And these are what the discs look like. They were grossly failed. And you can see the weave had just come unwoven. And this is the other disc. So, osteolysis, is it device design related? Again, let's go to the MOD reports. And so, looking at the incidence of reported osteolysis. This doesn't mean that 30% of all M6s have osteolysis. It means 30% of the reported complications with M6 in the MOD base, which again is voluntary, is osteolysis. This was new. The Simplify seems to be in second place. It was pointed out to us actually by Dr. Nunley in Shreveport. So we started looking into Simplify and diving a little bit deeper as we learned about that as well. Otherwise, pretty low incidence across the board. This was the landmark paper from Australia. Our friend Matt Scott Young was doing, has a robust arthroplasty practice. And he was told from a surgeon in Sydney, hey, of the 6 M6s I've done, 5 have gotten osteolysis. I've had to revise them. So he went back and looked at 53 of his M6s, and he had to revise 18 for incidence of 34%, whereas his revision rate with all others was 3%. So that really stuck out. And he reported it, took a lot of grief for it. You get a lot of arrows when you point something out that industry doesn't like. In his paper, he talks about one of the interesting things is, and again, I'm not a biomechanics expert, the way that the elastomeric discs are tested for their FDA pre-testing is the same way that ball and socket, and that just doesn't make sense. That the biomechanic testing is the same. I'll leave it at that because I just am not sophisticated enough in it between the difference between the type of testing. But what this did is this caused the Australian, they call it their TGA, which is their FDA, to put a warning label in the prosthesis packaging about to be vigilant of osteolysis. And as far as I know, there's only one surgeon left in all of Australia that's using M6. This was another study from a different site in Australia that, again, found just an unacceptably high incidence of failure and osteolysis with the M6 prosthesis, and their conclusion was very strong. So, the true etiology of late cases of post-TDR osteolysis, it has to be on our radar screen. We need to kind of to do more studies and figure out truly the mechanical and biologic cascade that ends to that clinical scenario. So we're getting there. We've got a lot of hypotheses, but we've got a ways to go, but we're a lot further along than when we first started talking about this in the States 2 or 3 years ago. The incidence or the association with C. acnes, one of the arguing points that the naysayers on mechanical osteolysis was, it's an infection. Well, C. acnes, there's a study from India on first-time lumbar discectomies, and there's a certain percent that just grows C. acnes. So it just may be something that's symbiotic in our body. Obviously the shoulder docs have a lot more literature on this than we do, but we should be aware. In the degenerative or reconstructive, and I wish Izzy was here because this is in the Scully literature. They already have a name for it: unexpected intraoperative positive culture. So when this study was, they were doing revision on long lumbar constructs posteriorly. They just started culturing for C. acnes. Again, no sign of infection. and found 20% incidence in adult redos and 40% in pediatric. Their conclusion is, we don't know what to do with this data, but here's the data. But there's a lot of research going on gut microbiome and biofilms and things like that. What's pathologic, what's not. Could this be a reason for hardware loosening or pseudarthrosis in lumbar spine, reconstructive surgery? Again, Izzy can talk about that better than I can in that particular literature, because I know he's been culturing his redos for a while. So the problem with osteolysis is that some patients have no symptoms, like the patient I showed earlier. Most of them do, though. A rare presenting, only one in our series, presents with dysphagia, because you can get a soft tissue swelling prevertebral. And one of our patients presented back to us, a study patient, from an ENT saying there's a soft tissue mass in front of the spine. What do you want to do about it? And there's a paper. Here's a small series. I think this is a European study as well, looking at that exact same thing. And those were C. acnes along with osteolysis. So there's something there from an inflammatory, biologic nature in addition to just the mechanical. So, radiographically, be suspicious. Look at your patients, particularly the medium, intermediate to long-term follow-up arthroplasty patients. If progressive radiographic changes are noted, consider doing a CT scan. If it's progressive, it's salvageable. Unfortunately, most of the time, unless you catch it really early, there's not enough end plate to do disc, so you've got to do an ACDF. It's rare, but it does occur, so be mindful and be vigilant. Theory, we talked about it, mechanical failure leading to accelerated wear debris, inflammatory macrophage infiltration, and then when does the colonization become an infection? Who knows? But this is just this was in, I think, one of the papers. This is just a proposed kind of easy treatment algorithm. If you see a suspicious X-ray on your follow-up from a cervical disc, get a CT. That's going to make or eliminate the possibility of that diagnosis. If it does show positive and it's early and there's just a little bit of a hint of osteolysis and otherwise mechanically stable and asymptomatic, I think you could follow this. I don't think you have to revise every one. If it's unstable, if you're worried about the integrity of the end plate or the disc moving, or if it's progressive, I think even if they're asymptomatic, it's appropriate to recommend a revision. And obviously, if they're symptomatic, you want to help your patient, you're going to do what you need to do. So, kind of getting to the concluding part of the talk, obviously very, very strong data with long-term follow-up on cervical disc. It's here to stay. When the money follows it, like those early slides, it's here to stay. It's got a great safety profile. It's well studied in the academic literature. While there are failures like we talk about here, and if you listen to a talk like this, if you were not a doctor, you'd say, why should I do it? But the incidence, as you see, it's very, very low. Revision's rare, as you've seen. You can always go back to your stock ACDF. If it's really bad, corpectomy we've had to do once or twice for a 2-level with intervening osteolysis that's destroyed kind of the middle vertebrae. Posterior, as you saw on Dr. Sattin's case, if you need it, for multi-level. And then revision disc to disc, which is something 5-6 years ago we hadn't really even thought about, but under the right circumstances, I think it's a great option. What we need to do is on those revision disc to disc is do a clinical study to see how they compare on the outcome measures to the index level that does patients that do well and don't need revisions. In other words, compare them to the IDE trial kind of patients. Disc to disc, good end plate, no gross infection, no advanced osteolysis, and then a lot of times the patients just say, I don't want a fusion, because a lot of them got a disc in the first place because they didn't want a fusion. This is a really busy slide. It's in the paper that we published. This is really just kind of first pass at our thinking and our proposed algorithm for a patient that comes back after cervical arthroplasty and just isn't doing well, whether it's clinical, radiographic, or a combination thereof. And if anybody wants this slide, they can have it. I'm going to show case 59 before I end. And this was this week. 44-year-old female, radiculopathy, C5-6, underwent Simplify in 2021. And you can see here, back in 2021, very happy with the implants. Okay, positioning, it's not perfect, but it's okay. And then something starts to be going on as we see 2023 and 24. It's definitely subsided, maybe HO, maybe going on to autofusion, but patient's doing well. So it's like, okay, what do we do? Patient's doing well, come back in a year. So this year patient came back and we're a little bit more sophisticated. And so I said, we're gonna get a CT scan just to be sure. If it's just subsiding and autofusing, we're not gonna need to do anything. Well, that's what we got. And patient's doing fine. You show them their x-ray, and then immediately they say, well, I think I do have some neck pain, But that wasn't the intent. I wasn't trying to talk anybody into surgery, but, this is a very alarming appearance. It almost looks like the posterior cortex is trying to get blown out, whatever. But this was the second asymptomatic patient that we recommended revision for. And we just did that this week. Here's the pathology in this particular disc that we found. Number one, it was the inferior end plate, the one that subsided, was cracked. You can see here what happened to the titanium coating. It had delaminated. It delaminated a little bit on the upper one, but there was not much metal left here. So it came out pretty easily. It left a little bigger cavity because we had to burr out the cysts. So we had to do partial corpectomies below and above, and had to use a bigger cage. Do not have cultures, do not have pathology back because we just did it 3 days ago. But we'll be monitoring the 2-week C. acnes cultures. The protocol that we're using now is I'm sending the patients home on 2 weeks of doxy, just in case the culture comes back positive. At the 2-week visit, culture positive, we go the full 6 weeks. Culture negative, we stop at 2 weeks. Whether that's the right answer, again, it's an asymptomatic infection. Now if we get in there, and we've had 2, maybe 3 cases where there actually was gross pus on a revision, and on those I called ID and they got the full PICC line treatment. But if there's no obvious infection, the oral seems to be okay. So that's all I got. How'd I do? For 50 minutes, okay. And less than an hour.